Yes.
Okay, perfect. Well, I'm Dr. Cassandra Steimle. Thank you so much for having me this afternoon. I just wanted to spend this time to talk about colon cancer screening. I am a gastroenterologist here in town in Dayton. Of course, this is something that we are very passionate about. Colon cancer screening is really one of the main procedures and something that we all care a lot about. So I just wanted to spend some time to kind of go over this with everyone. So thank you again for having me. To start with, these are sort of the objectives I have for all of us to get out of this presentation. I'd like you all to become a little bit more familiar with colorectal cancer, with the risks, that are associated with colorectal cancer, as well as the importance of screening for colon cancer, how to screen for colon cancer. There are different ways we can screen for it. So I'd like to kind of touch on those briefly throughout the presentation, along with the strengths and weaknesses of all of the different screening modalities. And then lastly, to better understand the whole experience of the colonoscopy procedure. So to start with, just what is colon cancer? Colon cancer is cancer that involves the rectum as well as the colon or the large intestine, also known as the large bowel. So just looking at an anatomy photo here, I don't know if you can see my cursor, but colon cancer can affect anywhere inside the rectum, which is just inside the anal sphincter, and then can extend anywhere up through the entire large bowel. The large intestine sits in the abdomen. It connects to the small intestine. And the main role of the large intestine or the colon really is to reabsorb water and electrolytes, and then to excrete any waste from the body in the form of feces. This here is an image of what colon cancer or colon malignancy looks like, and this is what we can find on colonoscopy. Obviously, our goal and the purpose of screening for this is to avoid this from occurring and to prevent colon cancer from happening in individuals. So a few stats. This is all data from 2020, but within the United States, colon cancer is the third most commonly occurring cancer in both men and women. In 2020, there was just over 126,000 new cases of colorectal cancer diagnosed in the United States, with just over 50,000 deaths being related to colon cancer. And in Ohio, in particular, there were just over 5,000 new cases diagnosed in 2020 alone. Of course, with 2020 data, that may be a little bit skewed, of course, with COVID and our facility as well as other facilities across the country were shut down at that time. We were not doing a lot of screening testing because of the pandemic. So these numbers may be a little skewed, but nevertheless, obviously, it still is a big problem. And just looking more at a bar graph example here, this is, again, 2020 data. Colon cancer was higher among male patients rather than females. Looking more at ethnicity levels, there is a higher risk of colon cancer in African American males. And you can kind of see the breakdown here versus African American, white males, Hispanic males, and then Asian Pacific Islander males. And the same data here is for female patients. Again, the highest percentage were among Black or African American females, but you can also see the breakdown here between Hispanics and white non-Hispanic females too. What are the risks for developing colon cancer? When we think of colon cancer, we kind of break it down into two categories. So we think of sporadic colon cancer, meaning it just develops without any genetic predisposition or family history of colon cancer. And then we think of a genetic component to colon cancer. So as far as cases of colon cancer go, sporadic is definitely more common than genetic. So again, sporadic meaning that there's really no family history. It just for whatever reason, colon cancer develops. Risks for this include increasing age. So we do know that after age 50, patients have a higher risk of developing what we call polyps. And polyps are small growths that can transform to colon cancer. Likewise, there's also a higher risk of developing sporadic cancer in patients who have a higher BMI and who are less physically active. As far as genetic cases go,
Yes.
we do have, I'm sorry?
Oh,
Okay. As far as genetic causes for colon cancer goes, there are several genetic conditions that increase your risk of developing colon cancer. These are very rare. They really account for about less than 10% of cases of colon cancer. And then we have other cases where patients may have a strong family history of colon cancer without any set diagnosis of a genetic condition. And this accounts for about 25% of cases. So, in general, the majority of cases are what we consider sporadic, again, just occurring without any genetic predisposition. Other risks for colon cancer, like we saw in the bar graph slides a few slides ago, is that polyps in colon cancer are more common in male versus females. And then looking at race, we do know that African Americans have a higher risk of developing colon cancer. They have a higher risk of developing polyps, particularly large polyps, which have a higher rate of turning to a cancer. And they have a higher rate of developing cancer at a younger age, so less than age 50. And this is just a schematic here of how colon cancer can develop. Typically, what happens is within the colon wall or the lining of the colon, for whatever reason, a group of cells starts what we call hyperproliferating, or sort of rapidly dividing, and those dividing cells can increase. Oops, sorry, skipped ahead there. Can increase and start turning into what we call a polyp. And those polyps are the little growths that have the risk of turning to a cancer. So polyps sort of resemble almost like a little pimple or a little skin tag within the colon. And then over time, those polyps can transform into from a benign growth into a malignancy or a cancer. And then again, if that's not identified, that can start invading the lining of the colon and then can spread through the body. So this is sort of a cartoon depiction of that. And then this is sort of what we see on colonoscopy. This over here is a polyp, a small little growth in the colon. And if that's not removed, it has the risk of increasing in size to a larger polyp and then eventually increasing into a colon cancer. So our goal for colon cancer screening is to catch this at the stage of the polyp and have it removed so that there's not a chance of that progressing to a malignancy. There are several types of polyps. The two main types that can cause colon cancer are going to be the adenoma polyps and the sessile serrated polyps. The other polyps listed here can be associated with other GI diseases. Are benign and they don't have any malignancy potential, but the two main ones that we want to look for on colonoscopy and any of the screening modalities are the adenoma polyps and the sessile serrated polyps. The adenoma polyps account for most cases of sporadic colon cancer, so about 70% of sporadic colon cancers develop from an adenoma polyp, and the remainder is usually from these sessile serrated lesions. And this will be important to know when we talk about the different ways we can screen for colon cancer, because some screening modalities have a better chance of picking up adenomas versus sessile serrated lesions. And therefore, you still have a chance of getting colon cancer even though you're doing these screening tests. Polyps also come in different shapes. So these are something that we look for on colonoscopy. We have small sessile polyps, which sort of look like that pimple appearance. And then polyps can also become what we call pedunculated and have almost like a little finger-like projection that we refer to as a stalk. Both of these have the potential of turning to a cancer. In regards to symptoms, polyps in general are asymptomatic. So typically, polyps are not going to cause any pain. They're not going to cause any bleeding or changes in your stools. You generally don't have any weight loss or any sort of systemic signs from polyps. And for that reason, that's why screening tests are recommended for any patient at a certain age, regardless of symptoms. Whereas with colon cancer, generally symptoms are associated with that, and that can include red blood in the stool, black stool, thin stools, diarrhea, constipation, abdominal pain, anemia, weight loss. All of those symptoms are what we call red flag symptoms that can be associated once a malignancy has occurred. Whereas with polyps, there's generally no symptoms associated with this. So looking at how we prevent colon cancer and how we can screen for colon cancer, that's the big thing. So when we think of cancers, any cancer, we want screening tests for cancer so that we can pick these up before they turn into something more severe. So for colon cancer, we have several tests available. There are stool tests, there are blood tests, and then there's what we call direct visualization tests, and this includes colonoscopy as well as CT scans, and then other less readily available tests like colon capsule, and we'll kind of touch on all of these briefly. In general, screening for screening for colon cancer starts at age 45. This is for what we call average risk patients, meaning for patients who have no family history of colon cancer and no family history of colon polyps. Previously, we used to start this at age 50 for most individuals, with African Americans being the exception and starting at age 45. However, a couple of years ago in 2021, those recommendations changed. We have been seeing more and more colon cancers being diagnosed and found in younger individuals. And so the recommendation changed for all average risk patients to start at age 45. And in my own practice, I've seen that as well. I've diagnosed colon cancer in several young patients, and advanced colon cancer in patients who were just at age 50. So I agree. I mean, I think we were all pleased that the recommendation finally changed, and that people are getting screened at younger ages now. For high-risk patients, these are going to be patients who have a family history of colon cancer in first-degree relatives, or who have a family history of colon polyps in first-degree relatives. The screening guidelines change a little bit for these patients. So rather than 45, we typically recommend age 40 or 10 years before the youngest effective relative, meaning if you had a family member, a parent, or a sibling who was diagnosed with colon cancer at the age of 40, then we would recommend that your screening starts at age 30. So if you have a family history in first degree relatives, you are at a higher risk of developing polyps as well as cancer. And that's why we push the recommendation down to a younger age for these patients. Between 75 and 80 is generally when we stop screening, and that number can kind of fluctuate a little bit. There's a little more leeway there, and really that decision is more individualized based on the patient's overall health, their comorbidities, and whether or not they're strong enough to go through the procedure. To start talking about the screening modality tests, we'll start with talking about the stool tests. And we think of these stool-based tests as what we call a two-step screening process, meaning that the first step is completing the stool test, and then the second step, if needed, is doing the colonoscopy. So the first test is the FIT test, which you may have heard about, and this is a single stool sample that's submitted. And this test looks for blood cells or hemoglobin that's shed in the stool. There are some limitations with it. If you have hemorrhoids, if you have any kind of inflammation of the colon or the rectum, or any irritation in the rectum, that's going to prompt this test to become positive. So it can be positive for reasons that are not related to polyps or cancer. In addition, you can see here, these two pictures that I have on the slide are two polyps. So the bottom one is that typical adenoma polyp that we talked about. And then the top one is the sessile polyp that we mentioned earlier. And you can see the differences on the adenoma polyp. There are small blood vessels on the surface of that. Versus on the sessile polyps, you can see the tissue looks the same color as the colon tissue. And so that makes a big difference when we're thinking about screening tests, because the vessels on the adenoma polyp are going to shed hemoglobin that will be picked up by FIT tests and other stool tests. Whereas the sessile polyps don't have those blood vessels at the surface. So they're not going to be shedding hemoglobin. And therefore, these polyps can be missed on the test. If you do choose to have screening tests with FIT, the recommendation is to have this done every year. So it is something to keep in mind. This is an annual test to do. The other stool-based test that's available is the multi-target stool DNA test, which is also called Cologuard, which you may be familiar with. And there's been a lot of advertisement for this. And this, again, is a single stool sample that's submitted. It does look for blood cells similar to the FIT test, but in addition to that, it also picks up different DNA samples from the stool, which increases the likelihood of finding a colon cancer. So colon cancer, in addition to shedding blood cells, also sheds different DNA material. And so the thought was that combining this in one stool test will increase the rate of finding a colon cancer, which it does. It has a pretty good chance of finding colon cancer. The issue with Cologuard and this DNA stool test is that as we age, as age advances, the normal process is to shed DNA samples and DNA cells. So, you know, as you get older, you're normally shedding this. So this is picked up by the stool test, just in normal patients who do not have any colon cancer, meaning that it has a high false positive rate. So it has a high chance of this test turning positive without there being an actual colon cancer. And then remember, this is still part of that two-step colon cancer screening. So any positive Cologuard test requires a colonoscopy to be done. And so, there is a large amount of patients who are getting colonoscopies done for a positive Cologuard test, and the colonoscopy is normal because the test is falsely positive. And if you do choose Cologuard or the stool DNA test as a screening modality, the recommendation is every 3 years to have this done. Other tests which aren't used commonly anymore are the flexible sigmoidoscopy. So this is an endoscopic procedure. This is looking inside the colon with a scope. The difference between this and a colonoscopy is that it only looks at the rectum and the lower left side of the colon. This used to be how colon cancer screening was done many years ago. It was thought initially that colon cancer was more predominant on the left side of the colon, and so the right side actually was not evaluated at all. This is 20 plus years ago. But now this is really kind of outdated for colon cancer screening. We do flexible sigmoidoscopies for other reasons all the time, but for colon cancer screening, this is really outdated and is not done anymore. Then there are a couple imaging tests that are available. The CT colonography or CT colonoscopy is an available option. With the CT scan, you still have to drink a full bowel prep. So you still need to do a full laxative to get cleaned out before the imaging test. It does not do the best job at picking up polyps, especially small polyps. So small polyps less than 1 centimeter can be commonly missed on this test. And then, of course, you're having a CT scan done, so you are being exposed to radiation. So there are some risks with that too. This test is done every 5 years for screening. There is a colon capsule test that is done outside the United States. We don't do it much here in the US. It has a really low chance of picking up polyps, and really it's not readily available. So that's not something that we do here. And then lastly, there is a blood-based test that has been studied. This is just a blood draw that's done. But again, this hasn't been shown to really give any good evidence whether or not there are polyps or colon cancer. So again, this is not something that we do. So among the screening tests that are non-invasive, we have the stool test and really the CT scan. And then moving on to the colonoscopy, this is what we call a one-step screening. So meaning you do the colonoscopy, and this is how we find polyps. Everything can be done during the colonoscopy. You don't have to go for additional testing. Whereas with the CT scan or the stool test, if those are positive, then a colonoscopy is needed as a second step. So colonoscopy is nice in that it allows us to detect and find polyps at the time of the exam. We can remove them during that time. Studies have shown that there is a reduction in mortality from colon cancer after a screening colonoscopy versus the other screening tests. The nice thing is, if the colonoscopy is normal and you do not have any family history of colon cancer and you're an average risk patient, then you can wait 10 years for your next screening test. And the test in general is, you're pretty comfortable during the whole test. You're given sedation. Whereas in the past, for the flexible sigmoidoscopy, these were done without sedation. So there was a lot of patient discomfort. Now we use sedation for all the tests, and it is a very comfortable experience. This is an example of what the colonoscope looks like. So in the procedure room, there is a processor. This end here is attached to the processor, which allows us to look inside the colon, to take pictures of the colon. And then this scope here, which is about 5 feet in length, is what is used to do the exam. The colon is usually about 4 to 5 feet in most individuals. So this gives us the appropriate length to examine the entire rectum and colon. And what we do is we insert this through the anal sphincter into the rectum and then advance it up through the colon here. So we're looking at the entire left and right side of the colon. And of course, we're looking for those polyps. Those are the little projections that can turn to cancer. And we do have different tools that we can use to remove those. So this tool over here is a little biopsy forceps. We can just sort of grasp small polyps and remove with this. This over here is called a snare, which is more of a lasso shaped utensil that we can use to wrap around the polyps and cut them out. When I talk with patients about colonoscopies, I think most of the questions stem around the bowel preparation. And so this has changed drastically over the years. Years ago, we used to use this gallon jug here, which has a terrible taste. It was a large amount to drink. It was very difficult to tolerate. There was a lot of nausea. There was a lot of vomiting with it. It was just not a very pleasant experience. And luckily, the preps have improved since then. So we generally don't use this gallon jug anymore. We have more gentle preps now that are available that are what we call low volume, meaning you're not drinking an entire gallon anymore. This prep over here is what I use commonly. It's called Plenview, and it actually just has 2 packets of a powder that you mix with water. And after mixing that, then and drinking that, then you drink two 16-ounce servings of regular water afterward to wash it through. The prep over here is called Soup Prep, and this comes with 2 pre-made bottles of prep, which are about 12 ounces each. Again, you drink a dose and you wash it down with regular water. We also have the option now for tablet prep, which is called Sutab, and that came out a couple of years ago. And this is 24 tablets that you drink in 2 split doses, again, followed by several glasses of water. So the prep itself actually has improved. Again, it's not as much that you have to drink. It's definitely better tolerated, and they're continuing to improve. So actually later on this year, there's going to be another bowel prep coming out called Soufflave, which supposedly has a taste similar to Gatorade. It's better tasting. So, we're continuing to work on improving the preparations. Now, moving on to discuss the process of a colonoscopy. Um, Generally, the day before the scheduled procedure, patients are on a liquid diet. So there's no solid food. We give you a handout of all the approved liquids that you can drink. You can have broths, you can have popsicles, you can have sports drinks, anything that's not red or purple in color. Around noon that day before the test, you take 2 Dulcolax tablets, and those are 2 laxative tablets that you take to kind of jumpstart the bowel prep process. And then that evening, around 5 or 6 p.m., you take the first dose of the prep. So if you're doing the pills, you take 12 pills at that time. If you're doing the powder prep, you take 1 packet of powder at that time mixed with water. If you're doing the pre-made bottles, then you drink 1 bottle. And then again, you're drinking at least 16 ounces of water after that to wash it through. The day of the procedure, you do another dose of that prep about 6 hours before your scheduled procedure. So that's going to be, again, either another 12 tablets or another powder packet or another pre-made bottle. Again, you're washing that through with a lot of water afterward. And then 4 hours before the procedure, you stop drinking. And then you come into our facility for the procedure. And what you're going to expect that day is you're going to be welcomed in by the nursing staff. They'll go through all your past medical history, all your surgeries, all your medications. You will receive an IV to receive sedation for the procedure. Once the IV is placed and everything is done by the nursing staff, then you're taken back into the procedure room. The colonoscopy procedure itself is usually on average about 30 minutes. You are asleep during that whole time. No, the procedure is not started at all until you are asleep and comfortable. In general, you're here at the facility for maybe 2 to 3 hours, including the time to check in and the time that we watch you afterward. Because of the anesthesia, we do generally watch you for at least 20 minutes afterward just to make sure you're feeling okay once you wake up, make sure your blood pressure is okay, make sure that you can tolerate some water. You do have to pass gas before leaving the facility, so that's another thing that we look for. But then once you're up and you're feeling fine, then you are okay to go. You can eat after the procedure is done. You cannot drive that day, so someone would need to drive you to the procedure. But in general, the process is not that bad. And I think a lot of patients who have been hesitant about having a colonoscopy done in the past and finally decide to do it, I think that's generally the consensus is that, oh, it wasn't as bad as I thought it was going to be. I mean, we try to make it um, an easy experience for you. Um, Generally, the prep is the worst part. And like I said, we're trying to make that part better for you as well. As I mentioned, all polyps are removed at the time of the colonoscopy, and those all get sent down to the lab. And generally, you receive results. The physician receives results within a few days, and then we either call you or mail you a letter in a couple of weeks with the results. Some concerns I hear from patients about colonoscopy, again, usually stem around the bowel prep. So, there are always concerns about either the cost of the bowel prep or the availability of the bowel prep at the pharmacy. I will tell you that with our office, and I'm sure most GI offices, we do work to get you samples of a bowel prep if needed. I never want you to spend a lot of money on a prescription laxative to have a procedure done. So if the cost is too much, if it's not available to you, you can always let us know. We will always work to get you a free sample if you need it. Um, there's also a concern about the colon not being clean and having to repeat the procedure. I will tell you that if the instructions are followed correctly for the bowel prep, it generally works, and we rarely have to have patients repeat a procedure. There are some instances in patients who suffer with perhaps chronic constipation or who are on chronic narcotic pain medications that can lead to constipation. Sometimes there is a little bit of a challenge getting those patients cleaned out completely. We're getting all the stool out of the colon. But in those cases, we usually give you what we call more of an extended prep and pre-treat with some Miralax several days before starting the bowel prep. So in general, the preps that we have work very well. It's very rare that we have to actually repeat a procedure because the colon is not cleaned out. Of course, the colonoscopy is an elective procedure, so there are, of course, some risks associated with it. The risks are very rare. The two biggest risks are probably perforation and bleeding, and you can see here that per 10,000 people, the risk of perforation or causing a tear in the lining of the colon is about 4 per 10,000 patients, and with bleeding, the risk is about 8 per 10,000 patients. There is a risk with anesthesia, like there is for any procedure, mainly with heart or lung problems related to anesthesia. And then, of course, going through the bowel preparation and inducing so much diarrhea, there can be a risk of dehydration or issues with electrolytes, which again is why we really promote drinking the Gatorades and sports drinks the day before to help prevent this. The risks in general increase with age. So again, that's why I mentioned earlier generally after age 75, we really have to stratify and determine if patients are strong enough to go through the procedure. But for patients who, don't have any comorbidities, are relatively healthy, the risks are very, very low. And just reminding you here that if the colonoscopy is normal, then you don't have to have another screening for at least 10 years. If polyps are found, then the recommendation does change, and it may be 5 years or 3 years or even 1 year for the next colonoscopy if more than 10 polyps are found. But if everything looks normal and you're an average risk patient, then you can wait an entire decade to have screening done again. So just to sort of wrap up the presentation part here, I just really want to stress that, colon cancer is the third most common cancer in both men and women in the United States. I believe screening is critical. We have great screening techniques and they should be utilized. There are different options with strengths and weaknesses for all options. I still think that colonoscopy is the gold standard test for screening. I think it's most efficient in that it's a one-step process, and it does give you a long interval before the next screening if it is normal. The new bowel preparations are much easier to tolerate, and like I said, we're continuing to improve that. So I just like to say thank you for having me talk about this. It is not National Colorectal Cancer Awareness Month. That's in March, but I just wanted to remind you that colon cancer is preventable, it's treatable, and it's beatable, and we have a lot of good screening tests for it. So if there are any questions, we can take some now.
Hi, you guys. We are going to take questions at this point. Is there any questions for the doctor? And why everybody's thinking about it, you can unmute yourself and actually ask the questions. I had one little sub question.
Yeah.
I know that you went over a few things with the different type of testing. Why can't you just take the pill and clean yourself out? Why do we have to still take that big old jug of stuff? Is there any reason why we have to do that? I know you mentioned it. Okay.
Yeah,
There it
so
is.
well, there's a pill form. I mean, it's several pills that you have to take, but as far as just like one, one laxative pill or something like that, really what happens is there's bile that is released in the colon, so not just stool, and the bile forms like a film along the colon lining. And so regular laxatives that you get over the counter don't really get rid of that bile film. So it just kind of expels the stool. So the preps that we have all been studied to clean out both the stool as well as that bile. And that gives us that clean colon lining so that we can find small polyps. If there's bile that's still kind of coated against it, it's hard to find polyps that way.
Okay, thank you for that. I'm one of those people that was in the risk category. With my grandmother, she was diagnosed at 50. And so I was supposed to start getting mine at 40, but of course COVID happened. So I'm in the process of trying to do all of that. I just don't like that stuff. It looks like it's going to be nasty to drink.
I didn't have to drink that, Jamila. I took Miralax and Docalax with Gatorade. That's the instructions that I was given.
Oh,
yep.
okay.
Yeah, there is a Miralax prep too. Yeah. In addition to these ones that I have here, the powder and the pre-made one, there is a Miralax option as well.
Okay.
Okay.
Yep.
Thank you. Any other questions? Anybody would like to unmute themselves to ask our doctor while we have her here?
I was late hopping in, but I just saw, are there any colon cleansing processes that may help prevent colon cancer, like colon cleansing pills or enemas? That came through in the chat.
Yeah, not that I'm aware of, none that have been studied. There are some research studies that suggest that maybe taking a low dose aspirin can help prevent the colon cancer from developing. But as far as actual like colon cleanses or anything like that, there's nothing that I'm aware of.
All right, thank you.
Yeah.
And I think I heard you mention earlier that family history, the genetic trait does not increase your risk significantly for colon cancer, but the screenings are still recommended more frequently for people with the family history.
No,
is that
yeah,
correct?
if you have family history in first degree relatives, then you are at a higher risk. of developing colon cancer. So yeah, even if your colonoscopy or, you know, your stool test is negative, we still recommend screening every 5 years for those patients because you do have a higher risk.
Do we have any other questions before we wrap up our lunch and learn for today? I'm trying to click back and forth to make sure I'm not missing anybody.
Oh, I think someone.
How often should you get checked for colon cancer if you don't have any family history? I think is what was being asked.
If you don't have any family history, then if you choose colonoscopy and yours is normal, then it would be every 10 years.
Would anybody else have any questions? I don't know if the chat box is popping up or not. I keep going back and forth to make sure that nobody's unmuting themselves. Okay, that was okay, thanks. Anyone else? Okay. Well, we definitely appreciate you coming to us today to talk about colon health. I know that is something that is, that's why we tape our sessions, because there's a lot of people that want to watch it and or participate, but they can't necessarily get off work to do so. I'm just making a few more minutes just to make sure that I didn't forget anybody. Did I miss anybody? Let me click on the chat box again, you guys. I'm sorry. I'm going back and forth. Okay. But we really appreciate your time to tell us about colon health today. And
yeah, of course.
everybody that is, oh, I'm sorry.
Oh, I just said thank you for having me.